Hey guys and shine, and welcome to the I Give a Damn podcast, brought to you by Fluorescene Media, the same company behind ODs on Facebook. Our guest today is Dr. Justin Schweitzer. Dr. Schweitzer is a master and presenter at glaucoma, post-surgical management, as well as various forms of ocular surface disease. In today's discussion, we dive deep into glaucoma and all of the new advancements coming out, whether it be in the diagnostic tools or even in the new medications, drug delivery systems, and new surgical procedures. So without further ado, please hit those like and subscribe buttons, and here we go with Dr. Justin Schweitzer. Dr. Justin Schweitzer, welcome to the podcast. Thank you so much for being here.
Excited to be here. Thanks for having me.
With for all of our guests, listeners who are listening here, who haven't met you or had the privilege to hearing you lecture, can you fill us in on just where you work and where you practice and what do you do?
Yeah, I'm at a ODMD tertiary care practice in Sioux Falls, South Dakota, called Vance Thompson Vision. We have multiple anterior segment surgeons. We now have added retina, we have oculoplastics, and then I work alongside a glaucoma trained, anterior segment trained surgeon. We have multiple optometrists in our facility as well. And my day-to-day stuff is managing really patients in the clinic with glaucoma, anterior segment disease, pre-operative cataract care, preoperative glaucoma care, those types of things. And the way that we're kind of set up is our optometrists really kind of manage and run the clinic. So the optometrists see the patients, prepare them for these different surgeries. Our surgeons are excellent surgeons, and they spend their time in the operating room. I kind of look at myself kind of like a middleman, meaning our referring network, our optometrists in the community will reach out to us to send a patient in for maybe a second opinion or for surgical care. We'll see that particular patient, the optometrist will, and then we will get them ready for surgery. And so I love what I get to do. I get to work with my colleagues and my friends, and then on the flip side, I get to work with my other colleagues and friends, the ophthalmologists in our practice.
I know the name Vance Thompson is even famous from Minnesota, where I live and practice. And it seems like it's grown quite a bit, right? It's not just like one facility. You guys have branches over a few states. Is that right?
Yeah, we've expanded. We have Bozeman, Billings in Montana. We're in Omaha, Fargo, Alexandria, Minnesota, Sioux City. I hope I'm not leaving one out or I'm going to get myself in trouble. But yeah, we've expanded. I've been there about 12 years now.
12 years.
And when I started, it was just Sioux Falls, and there was 3 ophthalmologists and 3 optometrists at that time, and it's much larger now for a good reason. It's grown for good reasons.
Yeah. And I know you is that right away where you started your practice, like out of school, or what's kind of your journey? How did you end up getting so involved in pre-surgical care and glaucoma and everything?
Yeah, it's a great question. It's not where I started. I actually, went to Pacific University. That's where I did optometry school at. I actually started in private practice in Sioux Falls, and just wasn't for me. Met John Berdahl, who's the surgeon that I currently work with on a daily basis, who's become a great friend as well. And just from sharing patients with him, working with him, we developed a relationship. I spent some time with him, ended up spending really a year doing a kind of fellowship residency with him, and then stayed on board with him afterwards. And that's kind of where I fell in love with kind of the anterior segment, the glaucoma piece especially. Managed a lot of glaucoma patients like you probably do, and many of our colleagues do in the private practice setting, but really got into advanced glaucoma and the surgical side of glaucoma with that year with him. And now I've been there for 12 years and love it.
And I know, again, I've seen you lecture on so many different topics, and I think even especially early in my career, I would find some of your lectures online that I would get CE credit for, and I get to learn from you for 2 hours about doing anterior segment evaluations, and I would just sort of take notes. So I think I've been learning from you for a few years now. But certainly, like you said, glaucoma is, would you say, kind of your first love of optometry, or is that kind of that's been a big subject that you've focused on?
Yeah, I wouldn't say initially I thought that was going to be the case. Yeah. Didn't, love it in optometry school. Probably like any student, you had different things you liked. Didn't probably love it right away when I started in private practice. But, with the advent of things like minimally invasive glaucoma surgery, so when I started at Vance Thompson Vision, we were involved in the first studies of the original eye stent. MIGS was just coming onto the market. And so that was fascinating to me. And so being able to be involved in a lot of those different things throughout my career thus far really excited me around glaucoma. Right. So I fell in love with it pretty quickly. And so, yeah, I manage a lot of other things, but glaucoma is definitely something that I'm very passionate about and continue to be passionate about, because there's a lot of changes that I'm sure we're going to talk about that are forthcoming.
Yeah, I wanted to ask you kind of about that, since you are somebody who definitely probably has their finger on the pulse of glaucoma, right? With glaucoma, at least let's start with management of just like, because before we can treat glaucoma, we have to first diagnose it. Right now, what kind of is new in either the theory about glaucoma or new tools that we have? Where are things at with the diagnosis of glaucoma?
Yeah, I mean, I think we're learning a lot about glaucoma, that it is an eye pressure related disease. But I always tell my externs, I tell my residents that if we get caught up in just managing intraocular pressure, you're going to underdiagnose and you're going to overdiagnose patients. We have to use all our different technologies. Glaucoma is a big puzzle. So when I think of the diagnosis of glaucoma, we want to use our visual fields. They've evolved, right? We now have, headset visual fields. Even the algorithms that we utilize on the Humphrey visual field, those things have changed. We have different 24-2C patterns. We have, faster visual fields to make it easier to hopefully get more reliable tests. OCT technology, need to use it. It's advanced. OCT angiography, great in retina, great for diabetes, great for macular degeneration. Making a little bit of a push too when we think about glaucoma. Our patients that have a myopic disc, hard to diagnose sometimes is their glaucoma. OCTA can be helpful for those patients. Patients that maybe are at the floor, severe glaucoma, OCTA, something to consider. We have different ways to measure intraocular pressure. New tonometer tips coming out, instruments that are maybe giving us more accuracy, measurements like corneal hysteresis. So there is a ton of diagnostic things out there. Handheld ERG, where does that fit in? A lot of different technologies. But I always stress, don't just cut up in one of those technologies. Think of it like a puzzle. Use the different puzzle pieces, put those together to get to that diagnosis of glaucoma, and then you have all these different treatment options to consider as well.
With the eye pressure being kind of the old, I don't want to say old school, but it is the foundation of just, how do we screen for glaucoma? I know there's been an uptick in kind of at-home monitoring of IOP. I don't know if you've had any experience with that, or what are your thoughts on that as being something doctors may be able to start offering their patients?
Yeah, I think we do. We utilize it at times. I don't send every patient home with it, but we have a couple of those devices within our practice that, glaucoma can be tricky sometimes. You'll have patients that will be progressing. You've controlled their pressure well. They come in for their visits and their pressure is always 11, 12, 13, driving you crazy. Why are they getting worse? Why is this patient getting worse? You need additional data. Right. That's nice to have at-home monitoring to be able to send home and see, well, what's happening in the afternoon? What's happening in the morning? And so it provides extra data. And so some of the at-home monitoring patients that I've had success with are patients that have been in that scenario. You send that monitoring system home with them. You find out, boy, their pressures are low in the morning, but they have a little spike in the afternoon. And so you can intervene in different ways. Now, is that compliance? Do they need surgery then? And I do think part of the future of glaucoma is going to be, what can we do at home for our patients? Meaning, are we going to have visual fields that we can do at home? We are.
Interesting.
It's already being looked at. There's some technologies actually out there already where we can do some at-home visual fields. At-home IOP or continuous sensor IOPs will eventually be here. There's continuous sensor IOPs in Europe right now being utilized. Called
I don't even know how they do that.
implant data. They're implanted. And so, then you'll have continuous data on intraocular pressure. And then I think at some point we're going to see an at-home OCT as well. And so a lot of this stuff, not that patients won't come into our clinics, but maybe we'll be able to minimize how many times they come into our clinic in a year.
That's fascinating to think of some of those new technologies, right? Especially if you think of how that'll change our understanding of glaucoma. Because, it's difficult to have a patient come in to do serial IOP checks, but like normal tension glaucoma, that's a pain in the butt to manage sometimes.
100%.
And so, maybe this new research from those devices like that implantable continuous IOP monitoring, how will that change our understanding and potential treatments down the road, right?
Yeah, we have good medications. We have new data coming out on SLT. We have good, MIGS procedures. by knowing some of this stuff at home, we'll be able to make better decisions for our patients. Right. Some patients where we may have intervened before, maybe we didn't need to intervene. Maybe we just needed to monitor. Or other patients that were progressing when their pressures were 11 and 12, maybe they truly weren't 11 and 12 all the time. They just happened to be that way in our office, and we should have intervened earlier. And so it is an exciting arena. The hard part is, we need to get it all. We need to be able to utilize it all.
With your own practice, you said do you guys use corneal hysteresis? What are some of your consistent go-tos that you guys have access to?
Yeah, we do use corneal hysteresis. I don't think I could manage glaucoma without it, to be completely honest. We've incorporated that over the last 8 years or so, up to 10 years. So I've pretty much had it the whole time I've been at Vance Thompson Vision, and I look at it just as a risk assessment. Just like when we look at thin corneas from the OUT study, risk assessment, I look at hysteresis, a low corneal hysteresis, being a risk assessment test. And so it helps to say, do we need to, intervene earlier? Do we need to be more aggressive? So it's not going to diagnose, but that's a great technology. You get some different, data from that. ERG, we've utilized a little bit of ERG. Again, I don't do that in every single patient, but again, when you have patients that have had more advanced glaucoma, our OCT technology isn't as advantageous anymore.
Right,
patients
they've
are at
hit
the floor.
Yeah.
So it's hard. So you need other technology, and the visual field's great, but how many of our patients, you can attest to this, can't take an accurate visual field? We can't just ignore it then, right? We still have to manage those patients. And so think about those other technologies like OCTA, ERGs, and things.
With how about treatments? Now, there's a lot of avenues and directions with treatments, but how about just like in the world of medications? Is there anything new that you're aware of that is either in the pipeline or is currently becoming available? Yeah,
recently, we've had, and they've been out for a little while now, but we have ROCK inhibitors that have been a nice addition. Just a totally different drug class. Anytime you get something like that that's unique, it's helpful. We have great prostaglandins. We've had prostaglandins for a long time. When we look at some of the new and upcoming things, there's been an emphasis on, the ocular surface. Preservative-free medications. There was just a preservative-free latanoprost that was launched that is going to be helpful to manage that. Because I would argue that a lot of our glaucoma patients, they don't really care about that nasal step that you and I are seeing on the visual field.
For sure.
We care about that. Our goal is to make sure that they don't go blind. That's our goal. But our patients don't know they have that. They care about their friend at dinner saying, "Why is your eye red?" Or "Why are you watering? Why are you dabbing your eye?" Because your eyes are watering. They're irritated. And so, taking that into account is important. So to have preservative-free options, we'll talk probably about SLT, MIGS. And then the newer stuff that's coming, which is exciting, is medications focused on lowering of episclerovenous pressure. And I'm interested in that because episclerovenous pressure is that backstop pressure that kind of is somewhere between 7 millimeters of mercury to 11 millimeters of mercury. Prevents some of our medications. We can't get pressures with medications typically down into the single digits. Usually you have to do filtering procedures, tubes, trabs, subconjunctival stents to get there. But these medications are focusing on lowering episclerovenous pressure. And I think they'll be a great addition if they have a good safety profile and they are efficacious to be able to lower pressure a bit more, and we can pair those with different things. So that's an exciting medication area.
Right. That's something I wasn't fully aware of that was being developed, but that's pretty exciting then.
Just because you're able to pair it with different things, and again, unique mechanisms of action. We know how PGAs work. We know how beta blockers work. Those things. This will be a different mechanism of action, which will be helpful.
No, we mentioned like SLT a little bit, and I think that's been an interest for probably, maybe a decade or so, because there's just been good research and more support for it. I think our partners over in more European countries, that's still like kind of their primary way to treat, isn't it?
Yeah, it should be in the United States now too, I think. When you look at the different studies that are out there, the LIGHT trial is the newest one that we're all pretty familiar with. 3-year data on that. We now have 6-year data on that. Up to or nearly 70% of patients being drop-free at 6 years in the SLT group. That's impressive. Earlier studies have compared SLT versus meds. Dr. Katz did a study on that, the SLT meds study again, showing that SLT as effective as medications. So nothing in glaucoma is going to be a fix. We can't cure it, but what we're trying to do, it's a marathon. We're trying to buy our patients time, let them keep seeing, help their quality of life, and SLT can do that. We can buy patients 3 years, repeat it, maybe buy them another 3 years, can vary a little bit, but if we can keep them drop free for a little bit of time, have this more interventional mindset instead of this patient-based mindset. And what I mean by that is interventional being physician-based, meaning you and I are in control, a little bit more in control. SLT is one of those things. MIGS, drug delivery, we're in more control of the physician. Patient-based being drops. The patient's more in control because if they're not taking it, they're getting worse on us.
Right.
And then you're frustrated because you're seeing these patients in your clinic and they're getting worse on you.
And you're worried that, no, the drop's not working. And it's just that they're just not taking it.
So that mindset to me is very important in the way that we think about treating glaucoma. A little more interventional, more physician-based, like we can control this because of some of the treatments we have, and SLT fits there.
And correct me if I'm wrong, but there is a new transscleral SLT, and I believe it was just FDA approved here in the U.S.
You're exactly right. Yeah, there's an SLT that will be able to treat their eyes very rapidly. We'll all want to learn if it's within your scope to be able to do it the original way, but it's an opportunity. The Belkin, the new SLT that is out there that's transscleral, like you mentioned, through the limbus.
Right.
You bet.
So it's those sort of things are just super cool, and it'll be interesting to see how that changes how many of ourselves and our colleagues practice throughout the country. I
think it has to be discussed as first line now. I think, we talk about drops with our patients. I think we have to talk about SLT too. It's got to be included in that first line therapy for our patients. And at times it may be, even second line added to drops. So I think it has to be discussed.
What about more invasive surgical procedures, or now we even have like an implant for IOP lowering?
Yeah, I would tell you probably one of the most exciting areas in glaucoma treatment is glaucoma drug delivery. To your point, you just mentioned, we have an injectable procedure, bimatoprost SR Durista that's been approved now for a few years. In-office procedure doesn't have to be done in the operating room. 28 gauge needle, it's injected, into the intracamerally, settles into the inferior angle. It's releasing bimatoprost. And you look at the data around it, it technically is releasing medication for 4 months. But there's evidence that patients get efficacy out to a year, for sure, 6 months, even out to 2 years.
Wow.
And so could it be a bridge? Help patients with ocular surface disease? I think so. And that's how I've utilized it in my clinic, is educating them. This isn't a forever thing. This isn't going to fix you forever, but how would you like a break from your drop or drops for as long as we can give it to you? 6 months, a year, 2 years. I'll get your ocular surface cleaned up, and then we'll deviate. We'll figure out what's next. And there's also a new one that just came out. It's an implantable one. This is done in the operating room right now, FDA approved now. We did our first cases about a week ago, called iDose. And so this is a travoprost implant.
Okay.
And so it's releasing Travatan. It's anchored in the trabecular meshwork. And there's good data showing 1 year results, 2 year results, and even 3 year results. So it may be efficacious even out to 3 years with drug delivery. It goes to our interventional discussion, physician-based. How do we remove the drops or the patient-based issues?
That question, you're removing that whole question mark out of the equation.
Yeah.
So what about, we're kind of leaning more into operating procedures, right, where they have to start going to the OR. What other what's the status right now with MIGS and with all the other there's always creative things I hear about. I don't do those procedures, so I'm not as deep into it, but I know you're exposed to it a lot more. Can you tell us more?
Yeah. And I'm like you, I don't do them either, but I'm exposed because of the practice I'm in with, the glaucoma surgeon that I work with, and he kind of does them all. But we think of stents. We have multiple stents on the market, which are perfect for patients that have visually significant cataracts, mild to moderate glaucoma. Those patients, low-hanging fruit. Cataract comes out, stents go in. You're probably going to get the patient off of medication. You're going to make them see better. You got a happier patient. You have goniotomies, which is stripping of the trabecular meshwork. So different procedures within that category that are being utilized can be done in combination with cataract surgery, but also can be done in pseudophakic patients as well. Again, probably a procedure that's going to minimize some drop burden for your patients that aren't tolerating medications. So another great option for patients. And then some newer things that have come out. There's a 3-stent device that's now available for pseudophakic patients. So actually 3 stents are placed in the trabecular meshwork. And these would be for patients that's failed with other surgeries, failed with multiple medications. So that's been approved for, a year and a half or so. So a definitely new one. And then we get into the more filtering procedures. There's subconjunctival stents A great procedure, but for more advanced glaucoma.
Sure.
We talked about episcleral venous pressure a minute ago. This bypasses episcleral venous pressure. So you'll see hypotony with it, and you have to be able to manage a bleb with it as an optometrist. You want to be comfortable with that. So it doesn't have the safety profile that the stents do and the goniotomies. But I'll tell you, if it were my eye, I'd probably rather fail with that device than go right to a tube or a trab, which is your big filtering procedures,
Right.
which come with some risk.
So with all of that, is that kind of what's new in the world? Do you know if there's anything in investigations or anything going out in that space?
Yeah, there's always things being looked at around that, combining different things. There's different filtering procedures that are being looked at that we haven't quite got yet here. The suprachoroidal space is a hot space that's being looked at. We don't have a device right now that accesses the suprachoroidal space. And the advantage of that space is you're bypassing episcleral venous pressure, but you're not having to do like a subconjunctival device where you're having to create a bleb. The suprachoroidal space, there's no bleb that would be in that area. So many of us probably remember a few years ago the CyPass stent, which is not on the market anymore. That was a suprachoroidal device. And so there's ongoing work in that space to be able to get a device like that because it would be very efficacious. You're bypassing EVP, but comes with less risk than some of those filtering procedures that we talked about.
Out of, with your patients, because you work in a pretty busy clinic, how do you manage educating patients about glaucoma? Like when you're first seeing them and you're like, I think you have glaucoma, maybe it's pretty advanced even at that point, but how do you manage really educating patients, supporting adherence, good compliance? What's your secret to helping your patients?
Yeah, I don't know if I have any secrets, but I think the first thing is to make sure that you address the fear that the patient probably has. Like for us, we're comfortable with a lot of these conditions of the eye because we see it every day. Mm-hmm. And it can be very easy to just take it for granted that you're diagnosing glaucoma all day long. But what you have to remember is that patient sitting in the chair, it may be the first time they heard of it. And so I try to start off every conversation with, you do have glaucoma. I know you'd heard of that from, in my case, a lot of times it's being referred in. And I want you to know that I'm going to do everything in my power to not let you go blind. And if it's mild glaucoma, I'm pretty confident telling them that. More advanced glaucoma, my wording might be a little bit different. But I think just making sure that you address the fear that the patient probably has, they may not show it, but you want to address that. And then I get into the education around the treatment options. And when I first started, I mentioned earlier, it was put a drop on the eye, put a second drop on the eye, put a third drop on the eye. We didn't really have MIGS procedures. You had a trabectome at that time, but we didn't have anything else. And then it was, now we're probably going to do a filtering procedure. Maybe we'll try SLT. Mm-hmm. The beauty of right now, the way that we can educate is we can say we have tons of options. We have great drop options. We have a laser option, and we have good data around that. We have safe or safer MIGS procedures. So it builds confidence for me as the doctor and the patient when you can tell them, hey, we have a lot of different options to be able to manage your condition. And I am a big fan of showing my patients their visual field so they know what I'm talking about. I am a fan of taking them through what the optic nerve head does, what it looks like on the OCT. Does it take a little extra time? Yeah. But if you can build that trust with those patients, they'll talk to other people and they'll be with you for, the remainder of their life.
So you mentioned ocular surface disease. That's, just not to dive too deep into a different topic, but it plays a role with glaucoma, with all the medications, and now with different procedures. But what's been kind of the impact you've seen with kind of that focus, that shift in ocular surface disease?
Yeah, it's important. I mean, you see it in your practice. I see it in my practice. It's important for us all as optometrists to manage it, whether we're, seeing it and we're putting a patient in contact lenses or they're getting new spectacle lenses or you're sending them in for surgery. Mm-hmm. I talked about the quality of life issues we see with glaucoma patients. It matters to them. Cataract outcomes, advanced implants work really, really well, but they don't work well if the ocular surface isn't healthy and happy. Refractive, LASIK, PRK, the surface has to be healthy and happy. And so I'm an advocate for aggressively treating it. Could I do better? I'm sure I could, but I'm always aware of it. To me, any patient that walks in the door has ocular surface disease until I prove that they don't. And that's important with any of these procedures that we're talking about.
Right, especially, again, in chronic use of medications, preservative kind of I would say preservative abuse in a way.
Yeah, and it's more the number. I think, glaucoma medications aren't going anywhere. I think one medication, it can cause problems, right? There's studies showing that one PGA over time can create some meibomian gland dysfunction. But I think when you stack them, when you have multiple medications, maybe multiple medications with BAK, that's when you start to kind of run into some of the quality of life issues, and if they've been on it for an extended period of time. So having that kind of interventional mindset we talked about earlier, minimizing drops. How do we do that? What are our things? Glaucoma drug delivery, MIGS procedures, any of those types of considerations can help.
Another interesting question I have for you is because of AI. Now, it's a bit of a buzzword right now, but there are publications of kind of new software trying to utilize AI to study the optic nerve, to diagnose glaucoma and make management kind of suggestions. What are your thoughts on how AI may impact our profession?
I think it'll be helpful. I really do. It's not going to take the place of what we do. Nothing takes the place of the human heart. We care about our patients, and we need to continue to care about them. But it'll make us more efficient. In the glaucoma world, one system that you may have heard of is called Pegasus. That's a system that identifies optic neuropathies, and they did a study looking at Pegasus versus optometrists and ophthalmologists and identifying optic neuropathies. And the good news is we did really well. We identified optic neuropathies as consistent as what Pegasus did, but it's faster. It's just going to do it quicker. And so we're going to get more data, speedier. We're going to be able to take care of more patients. And just the sheer number of disease, especially glaucoma, but cataracts, all these other things, that is going to increase in the United States over the next coming, decades. We're going to need something like that. And so it'll be helpful.
And I think patients will like it too, because their exams maybe won't be as long.
Another added advantage.
The final question that I like to have for a lot of our guests now is, if you were elected by, let's say, the President of the United States decided they need a Surgeon General of Optometry, if you were elected to that position, what would be the first thing on your docket, the big change you would like to see in our profession across the board? What do you think that would be?
That is a good question. For everyone listening, this was not he doesn't hand me these questions beforehand, so this is the first thing that's coming to my mind right now. Good question. I would probably say we have a lot of talented optometrists in this country, and some of us are more talented at certain things than others, and that's a good thing. If you ask me, am I talented at understanding the retina at a high level? I'm dangerous enough to identify certain things, but I'm not like high, retina. What would I treat, geographical atrophy with, or what would I treat wet AMD with? That's not my specific area of expertise. And so what I'm getting at is I would lean on and refer within optometry a bit. That doesn't mean surgery. When a patient needs cataract surgery, they're going to see an ophthalmologist, and they're great at that. Or they need a glaucoma surgery, they're going to see an ophthalmologist. But for certain conditions, refer within to our colleagues, our friends, work hand in hand together, because we have a lot of talented doctors.
I love that. And I think that is a huge, you're not the only one to kind of mention that here on this podcast. Like that's something that we as a profession, I think, are doing, but we need to kind of accept that a little bit more and band together. So
I completely agree.
Well, Dr. Justin Schweitzer, thank you so much for being here on the podcast, for being one of our I Give a Damn leaders. From here, I just wish you to have a great rest of your convention here, and then hopefully we'll have you back on as a guest on another topic, because you've got a lot to say.
Well, thanks for having me. Love what you're doing with this. It's been a lot of fun. Thanks for the time.
So that was our episode for today. Thank you so much for listening in. Hey, I put a lot of effort into these episodes, and I really want to continue bringing the most value to you and our listeners. So if you haven't done so already, please, if you're watching on YouTube, leave us a comment, or if you're listening in on your favorite podcasting station, leave us a review over there. That'll really help us out. Thank you so much again for listening in, and keep an eye on it, and we'll see you in that next episode.